have this notion that alcohol helps sleep, but we know clearly that it actually causes sleep disruption and fragmented sleep, so avoiding alcohol. Having good practices, using your bed and your area of sleep just for sleep and nothing else. Avoiding medications that could be stimulating. Those are called sleep hygiene techniques that are very important. There's another entity called stimulus control therapy, which is really of taking out those external stimuli that impede sleep. So again, the bedroom, only using that for sleep is critical. So making sure that people go to bed when they are actually about to sleep, and not using the bed to play on their iPads or their high-tech devices. Using the bed for sleep, changing that environment where all that's done is really sleep. So that is very, very important. Another component is called sleep restriction. One of the things that's very effective as well is when you see, based on sleep logs or sleep diaries that we talked about, that patients are spending a tremendous amount of time in bed, so they have a increased sleep latency. It takes them longer to fall asleep. They're sitting in bed. What we can do is actually tell them to go to bed later and limit the time they have in bed. So by limiting the amount in bed and the time to sleep, you increase the homeostatic drive to sleep. So that can be helpful as well. And there's certainly a number of other things you can do, such as relaxation therapies. And these programs are programs that are really formal through different sleep centers, where they work with patients on relaxation techniques, biofeedback to really calm their nerves and help sleep. So all of these put together actually work better than any pharmacological therapy. And even if you are using pharmacological therapy, which often is necessary, you very often need to do this in conjunction to pharmacological therapy, and certainly have tried these behavioral techniques as well.
And then you mentioned the pharmacological therapy then. In this case, Dr. Murray said he was using benzodiazepines and propofol to treat insomnia. So I want to ask you about the pharmacological approach. And in your review, let me ask you, in your review of Dr. Murray's statement to the police, did you see any indication that a behavioral approach was attempted?
No, I didn't see anything. There was actually no documentation of any of the medical care that Mr. Jackson received.
Going then to the pharmacological approach, is it fair to say there are classes of drugs that have actually received FDA approval for the treatment and management of insomnia?
That's correct. There are really 8 kind of standard agents that are FDA approved for management of insomnia. These include 7 of them belong to the large group of drugs called benzodiazepine receptor agonists, and amongst those, 4 of these drugs are actual benzodiazepines, and 3 of them are non-benzodiazepines. The non-benzodiazepines are traditionally the drugs that are recommended as first line for pharmacological management of insomnia, because they have less addictive properties, they have less side effects, they tend to have a less of a significant negative impact on the quality of sleep and sleep architecture. And these are drugs like Ambien or Sonata or Lunesta. So these are the non-benzodiazepine receptor agonists that they're called. And finally, one of the more newer drugs are the what we call the melatonin receptor agonists. Remember, we talked about circadian clock in the brain that tells us when to sleep and that cycle of sleep. The melatonin receptor agonist, Rosarum, is another drug that is FDA approved for treatment of insomnia, and certainly can also be used chronically because it also has less of a risk for addiction in patients with insomnia.
And as far as benzodiazepines then, and as far as benzodiazepines that have FDA approval for the treatment of insomnia, what are those agents?
Well, they are triazolam, temazepam, flurazepam. So basically just Restoril, Halcyon, Prosong, and flurazepam.
There's 4 total?
Four drugs that are FDA approved. Now, the reality is that other benzodiazepines are occasionally used for treatment of insomnia in the oral versions. However, they're usually addressing an underlying problem. For example, an underlying psychiatric issue like anxiety for only short periods of time. The real goal is to use the least amount of medication that is effective as possible, and to try to titrate that off, to try to gradually take patients off as soon as possible without risking withdrawal from the drug.
And in regard to the FDA approval, the benzodiazepines that are approved, they're all in the oral form, like a tablet?
That's correct.
Not intravenous administration? Correct.
Yes.
Now, you're aware that in this case, Dr. Murray was administering Valium or diazepam? Yes?
That's correct, yes.
As well as lorazepam and midazolam?
Yes.
Specifically on those 3 benzodiazepines, and let's talk about first lorazepam and midazolam as an intravenous administration. Is that appropriate long-term care for insomnia?
No, absolutely. It's not. It really has no role for long-term management of insomnia.
And how about the Valium or diazepam, oral?
It really, the only times that those are used are if you're dealing with some underlying secondary cause for the insomnia, such as like an anxiety disorder. But really for primary insomnia, meaning once you've ruled out everything, that is not an appropriate management.
And again, for primary insomnia, once you've ruled out everything else, if you did take the time to rule out everything else, how about oral form of lorazepam? Can that be used on a short-term basis?
It can be used for a short-term basis, again, for patients that have some underlying secondary reasons like underlying psychiatric issues like anxiety. It can be used, but the problem there is with that drug is very highly addictive, and use beyond 3 to 4 weeks can really have an addictive nature to it, and it may be very difficult to really get patients off.
You're specifically talking about lorazepam?
Particularly, yeah.
It's a highly addictive drug?
That's correct. I mean, benzodiazepines in general are, and that's why I mentioned in general that our first line of therapy are the benzodiazepine receptor agonists, those drugs that I mentioned, the 3 earlier.
Thank you. And then in this instance, Dr. Murray's own admissions that he was administering both midazolam and lorazepam in conjunction, of course, with diazepam and propofol, but the lorazepam and midazolam by intravenous administration. You characterize that as an extreme deviation from the standard of care, correct?
Right, for the treatment of insomnia, absolutely it is, yeah.
And particularly in the way he was doing it via IV administration.
Route, absolutely.
Let's talk about then, you've talked about the benzodiazepines that Dr. Murray was using. Let's talk about your findings in regard to using propofol, specifically propofol for the treatment of insomnia. Is that in any way accepted or appropriate? No,
it really has no role for the inpatient or outpatient management of insomnia. There's really, it's really inconceivable to use this drug for that purpose. It utterly has no role in the management of insomnia.
You indicated that's regardless of the setting.
That's correct.
And in your findings, you state that the mere thought of considering propofol as a treatment option for insomnia is beyond comprehension. It is frankly disturbing. Why did you make that statement?
I think if you just step back and just look at this for what it is, and if you're just saying that here you have someone that you're diagnosing with really bad insomnia, particularly understanding that there are major secondary causes, and to be treating them with a potent anesthetic that has no proven role in management of insomnia is just really hard to really grasp. It's inconceivable.
And you state unethical.
That's correct.
And why is that?
Because there's just really it's kind of beyond a departure of standard of care. I mean, it's something that we would never even fathom doing. Really, any reasonable person managing someone with insomnia to be using propofol for that is really, there's really no reason for that.
You concluded that Dr. Murray acted with gross negligence and with an extreme departure from the standard of care, and that through his acts and omissions, he caused Michael Jackson's death. Is that accurate?
That's correct.
You state that additionally, although not supported by the evidence, if one assumes Mr. Jackson self-administered after being given high doses of benzodiazepines and propofol, Conrad Murray is still responsible for creating the life-endangering situation, failing to monitor, failing to have the basic equipment, abandoning his patient, allowing access to drugs, lying to medical personnel, and delaying in calling 911. In either scenario, Conrad Murray played a direct role in causing Michael Jackson's death. Those are your findings?
That's correct.
And would you agree that even under a scenario put forth by the defense that Michael Jackson self-administered either lorazepam or propofol after being given the drugs by Conrad Murray in this setting, that the risk of that happening would be a foreseeable thing that a competent doctor should have been aware of?
Oh, absolutely. I mean, here you have a patient that potentially may have substance abuse problems, or clearly it sounds like he had substance abuse problems, and you're providing this environment where drugs are readily available. They're not locked up there at an arm's reach. That is definitely a foreseeable complication. And when you have potent drugs, which in combination, as we talked about, can synergistically have such profound effects that we've discussed at length, that is very foreseeable.
And would you agree in a broader sense that when administering benzodiazepines and propofol, even a 25 milligram administration of propofol in this setting, that the risk of respiratory depression and cardiovascular failure is again a foreseeable risk that any competent doctor must know about?
I think this goes to the fact that there were many issues that together culminated in this. The underlying dehydration, his underlying condition, the synergy, the combination of those medications, the benzodiazepines and the propofol, absolutely, and that was something that was definitely a possibility.
And would you agree that respiratory and cardiovascular complications is a known and foreseeable and normal risk when you're administering benzodiazepines and propofol?
That's correct.
Thank you, Doctor. Nothing further, Your Honor.
Thank you, Mr. Walken. May I see counsel, please?